So I'm Carol Schwartz, and I'll be presenting for the first half of this presentation that we have on section GG. And I'll be taking you through a number of the scenarios that you folks will be able to opine on. And if you have your case study open for this, or rather the examples for this presentation, that would be helpful too. So then you can read through those. So section GG, Functional Abilities and Goals, is the name of this section. And of course, measurement of functional status has been recognized as a key indicator of quality for care for IRF patients and those with chronic disability or illness. And functional outcomes are a particularly important quality domain because of their value to the patient. The abilities to eat, bathe, toilet have been reported as the most valued activities for functional recovery from both IRF patients and clinicians' perspectives. And the positive impact of mobilization and post-acute care for functional gains toward previous baseline also reminds us of the importance of the outcomes measure. So we have listed a number of acronyms here so you can see them, but I'm not going to read through them, and you have a separate sheet for those as well. So today we're going to focus on prior functioning, admission and discharge, and self-care and mobility performance, as well as the discharge goals. The admission and discharge self-care and mobility items assess the patient's need for assistance with self-care and mobility activities. And your objectives at the end of this presentation, you should be able to describe the intent of the changes that we have made to section GG and explain the clarifications of the item definitions that we're going to be going over and apply the coding instructions accurately to these practice scenarios that I had mentioned. So that's where you'll be reviewing those as I go through them and describe the functional outcome quality measures as well. So of course the intent for patients in inpatient rehab facilities are to have that self-care and mobility limitation. They have self-care and mobility limitations, and they are at risk of further functional decline and complications due to the limited mobility. So that's why you folks are so important in having the patients begin to work towards their functional gains and outcomes so that they are not, and we lessen the risk for this. So let's look at the changes between version 1.5 and 2.0 of the IRF-PAI. So we've added a new code, code 10, and that is not attempted due to environmental limitations. So for the IRF-PAI, you would find that for some of your items that would be affected by weather constraints, such as car transfer, and lack of equipment may be perhaps an issue in terms of if you don't own a car or car simulator for practice. The updated guidelines, or rather, let's for example, so the updated guidelines for coding goals, use of codes 07, 09, 88 and 10 are permissible to now code your GG 0130 and GG 170 discharge goals. So that's also new. And also we've added incomplete stay skip patterns. If a patient has an incomplete stay, then you will be skipping the discharge self-care and mobility items. So that's also a new change in this version. So we've added skip patterns if the activity did not occur for the following walking and stair items. So you'll see this on GG 0170I, walk 10 feet, and you'll also see that skip pattern also appear if the patient is not able to complete the one-step curb, and again, if the patient's not able to complete the 4 steps. So you will have skip patterns that are provided for you there. We've also removed the walking gateway question at the admission for GG0170H1, which read, does the patient walk? So instead, you will see what we have replaced it with as we get into this presentation, and then also for the planned discharge, GG1070H3, you'll also see that eliminated. So we updated and clarified for alignment purposes these minor changes in wording, and these should not affect coding. So and or is added to these items that you see listed here on the first bullet, and then the second bullet or is added to read wheelchair or scooter in those items that are listed in the second bullet. For the third bullet, and since the coding instructions refer to safe performance, which applies, of course, to all self-care and mobility items, we eliminated the extra word safely that had appeared in some of the items. But now we see that word safely in the item definitions. So let's now talk about the data sets. So we added clarification defining code 09, and it's not really a new definition. We had used this information before. It's simply now on the form. And for 04, we use contact guard, as this is the term therapists use in terms of supervision or touching. So we just added that because that's a common term that therapists use, and wanted to just clarify that that's, of course, included. So now let's go into the coding guidance and the practice scenarios. So here are the section GG items at a glance, and you can see you'll assess them on the IRF-PAI at admission only or at admission and discharge. So this has not changed. So let's go to GG0100, prior functioning, everyday activities. So these items in coding remain the same. Your steps for assessment will be to ask the patient or his or her family members about his or her prior functioning, and you'll be reviewing the patient's medical records if needed as well to describe the patient's prior functioning with everyday activities in order to code these items. And notice the coding definitions and coding numbers are specific, as you'll recall, to these GG0100 items only. And they are independent for code 3, and code 2 needs some help, and code 1 dependent. Code 8 is used if unknown, and code 9 is used for non-applicable. Okay, so let's take a look at the prior device use, and that's, of course, GG0110. So here's the list of items that you'll be completing, and this is a check all that apply to what device the patient used prior to the current illness, exacerbation, or injury. So again, it's prior to the current illness, exacerbation, or injury, as their device use may change. So your steps for assessment are, again, to talk with the patient and his or her family and about which device use had been used, or the aids that had been used in the past. And also you can find perhaps those in medical records describing the use of prior devices and aids, and only report devices and aids used immediately, again, as we said, prior to the current illness, exacerbation, or illness. So you'll be checking all devices that apply here. You can see we've added the and or to the scooter. So some patients may own both a motorized wheelchair and a scooter, both. So checking all that apply here. Under B, in this example, B would include both. or it would include just one of the devices as apply. And if none of them apply, then of course you're going to be checking Z. So providers have asked us, a lot of times we get really great information to present to you because of your questions on the help desk. So this is an example of one of them when a provider had asked us, what are we speaking of when we talk about walkers? And so here we've listed the walker types that we are including here. So I won't read every one of them, but you have them listed here. So when you are going over this with your staff, you will have that here. So I'll be reviewing GG0130 self-care items and practice scenarios, and then Ann Deitch will be following up with the GG0170 mobility items. So here's your steps for assessment that you can apply both to the self-cares and the mobility items. You first want to assess the patient's self-care and mobility performance based on direct observation. That's our preference. But also you can also get information from the patient, self-report. You can also talk with other clinicians and care staff, and of course family reports, and this is all to be documented in the patient's medical record during the 3-day assessment period. Patients should be allowed to perform the activities as independently as possible. Please don't base the assessment on information provided by a helper to consider for coding if you have, upon questioning the caregiver, or in this case it might be a CNA or another staff member. Let's say if the patient was rushed because they were going to be late for therapy, and so more help was provided to that individual than actually necessary. So really make sure that what you get in terms of information from other staff is actually what the patient is doing and what they are capable of. So again, patients should be allowed to perform the activities as independently as possible as long as they're safe. And if a helper assists, assistance is required because the patient's performance is not safe, or they do not complete the task and it's of poor quality, score according to the amount of assistance that patient needs. So we continue here with activities may be completed, of course, with or without an assistive device, and this should not affect the coding at all. So someone can be independent even if they are using an assistive device. If the patient's self-care or mobility performance varies during the assessment period, be sure to record the patient's usual performance, not their best performance, not their worst performance, but their usual performance. So also we want to remind you to refer to the facility, federal, and state policies and procedures to determine which of your or staff members may complete the assessment. Patient assessments are to be done in compliance with those facility, federal, and state requirements. So let's talk a little bit about usual status. We've had a number of questions about usual status, and so we wanted to go over some points about that with you. At admission, the functional status of the patient should be based on a clinical assessment, and that should be done as soon after the patient's admission as possible. So we'd like to get that baseline, right, as soon as possible after that admission. And the admission function scores should reflect, of course, the patient's baseline prior to benefiting from therapeutic intervention. And that's why we emphasize that the baseline can be achieved as close to that patient's admission. Upon discharge, you're going to be coding the patient's discharge functional status based upon the clinical assessment that occurs as close to the time of that discharge. Regarding usual performance, it is that the patient's performance may vary for an activity, and you would determine what that usual performance is for that activity. And of course, it could be impacted by the environment or situations encountered at the facility, but observing that patient's interactions with others in different locations and circumstances allows you to get that more comprehensive understanding of what the patient's status is. And if the patient's status varies, report the usual ability. So let's take a look at the codes for usual performance for each activity using that 6-point scale. So code 006 is for independent, and we mentioned this, even if a patient is using a device such as an AFO, if they're putting that on themselves, that still can be an independent performance. Code 05 is for setup or cleanup assistance, and that is where the helper sets up or cleans up, but the patient is able to complete the activity entirely by themselves, and the helper is only needed prior to the activity being completed or after the activity has been completed entirely by that patient. That is 05. For 04, supervision or touching assistance, that's of course supportive or touching is provided by the helper, or we also include in 04 verbal cues or contact card as the patient completes the activity, and the assistance may be provided throughout or intermittently through that activity. So an example might be eating cues for not putting too much food in a patient's mouth who may have had a stroke and that has been compromised in terms of their judgment. It may be impulsive. 03 would be code for partial and moderate assist, and this is less than half of the effort. So in this case, the helper may be lifting, they may be holding, they may be supporting the trunk or limbs, but the helper is providing less than half the effort for the activity. So all tasks that are included in the activity definition should be well known by your clinicians in order to determine what portion of that activity is completed by the helper, right? So each one of those tasks that make up an activity needs to be understood so that you can determine the amount of assistance that was provided for the patient. 02 is substantial maximal assist. The helper does more than half the effort. So again, you have to know what it is that each activity is comprised of, and then look at that and determine if the helper did more than half of that activity. And then 01 is for dependent. The helper does all the effort for the activity. The patient does none of it, or there are 2 or more helpers assisting the patient to assist the patient. And even if the patient does a little bit with 2 helpers or more, that would still be counted as dependent. Okay. So during the entire 3-day assessment activity, if the patient does not attempt the activity and the helper does not complete the activity for the patient, you're going to be using one of our codes of activity not attempted. And I'm stressing that this is through the 3-day assessment. So you want to make assurance that you have sought out other clinicians to find out if the patient had done the activity that you are about to code as not attempted, to ensure that you can't put a 01 to 06 code rather than the not attempted code. So an example of that would be during the 3-day assessment period, the activity may not have happened during therapy, let's say oral hygiene, because the patient said, well, I've already done this. I don't need to do this again. So instead of coding as 07 that the patient refused, you could go on the unit, talk with staff members, ask and interview an interdisciplinary staff to find out if you could extract that information from them, and then you would not need to use these not attempted codes in this scenario. So that would be for 07, that would be how to avoid 07, but if the patient obviously refused that activity the entire 3 days, then 07 would be appropriate. And then for code 09 for not applicable, again, we want to emphasize that 09 is not attempted and the patient did not perform this activity prior to the current illness, exacerbation, or injury. So if a patient was put on a G-tube, let's say, for several years and was admitted to your facility and then did not continue to eat by mouth, then you would code eating 09 because the patient had a history prior to coming to your facility, right, of using the G-tube and not eating, and at your facility, that patient did not perform the activity in the 3-day assessment. So see how that becomes 09, not 88. So that's a very important distinction to know that. It's the history of them not performing that activity and what they're doing at that time. So code 10 for not attempted due to environmental limitations, I mentioned before that that would be a lack of equipment or perhaps weather constraints, and we'll talk a bit about that too when she gets to some of those items. And then code 88 is not attempted due to medical condition or safety concerns. So again, that's at present time, not the history of not doing that activity, but at the present time, at that admission, it is because of medical conditions or safety concerns. So let's go through step by step the key coding questions. So when you're teaching your staff members how to code, and this is of course a really important feature here in terms of the data integrity, is to be able to get those codes right. So here we're going to walk through, I'll move through a series of questions that will help you determine what the code is for each item. Okay, so first we would begin with the question, does the patient complete the activity by himself or herself with no assistance? And by that we mean no physical assistance, no verbal assistance, not any nonverbal assistance, no cueing, no setup, no cleanup. The person was able to do this on their own with no type of assistance. And if the answer is yes, then you would complete 06 independent. But if the answer is no, then you would advance to the next series of questions that will help you to determine the degree of assistance that's required. So you would go to next. If the answer was no, that the person was not independent, you'd go to the next question. Does the patient need only setup or cleanup assistance from one helper? Okay, so if the answer is yes, then of course you would code 05, setup or cleanup assistance, but if the answer is no, you would go to the next question. So this question would ask you, does the patient or resident need only verbal or nonverbal cueing or steadying or touching or contact guard assist from one helper? Remember, all of those things are part of 04, right? That verbal, nonverbal, steadying, touching, contact guard, that's all a part of code 004. So if the answer is yes, that's the only type of assistance they need, then you would code 04, supervision or touching assistance. But if no, you would then move on to ask yourself, does the patient need physical assistance? For example, lifting, trunk support from one helper with the helper providing less than half the effort. If the answer is yes, then you would code 03, partial moderate assist. And remember how we talked about that all of the different tasks within an activity is what you are considering and figuring out in terms of the 03 versus the 02 code. So in this case, partial or moderate assist, but if not, the patient needed more, then you would go and ask the next question, which is, does the patient need physical assistance? Again, the lifting, the trunk support from one helper with the provider providing more than half the effort. And of course, it's a 0-2 substantial maximal assist if that is true. But if no, then of course, it would be obvious if you have a patient that needs 2 helpers, automatically they're a dependent. But if in the case the patient does nothing, absolutely nothing in being able to assist with that activity, and they were dependent on someone doing it for them, then it would be 0-1. Okay, so for these reasons that the activity is not attempted, we talked a bit about this before, so I won't go through this as thoroughly because I did repeat this, but you have this information here in terms of 07, not refused, 09, not applicable. Again, we remember the difference between 09 and 88, the activity for 09 not attempted, or not applicable if the patient didn't attempt to perform the activity during the 3-day assessment period nor prior to the current illness or exacerbation, versus 88 when that's just because of the medical condition during that stay. And we talked about code 10. So some coding tips is when observing the patient, you want to review the patient's medical record, of course, and very important to emphasize and to restate interviewing your staff to be familiar with it and really getting them to understand the definitions, and we talked about that. So when coding the patient's usual performance and the patient's discharge goals, you're going to be using the 6-point scale, and new to this version is the ability to use the not attempted codes as well. And this will specify why the reason the patient's the activity was not attempted. And then at the time of discharge, you want to use the 6-point scale, or again, the activity not attempted codes to identify the usual performance at discharge. And then you don't want to record the patient's best performance. We talked about this. And you don't want to record the patient's worst performance, but rather the usual performance. When gathering the information on the patient, ensure that the patient was allowed to be as independent as possible. When you're doing those clinician interviews, we talked a little bit about making sure that you get to the bottom of it, is that the code, the true performance of that patient, or was it somehow impacted by the helper hurrying the patient along and doing more than they needed to. So it's very important to ensure that you are getting what that patient actually can or actually does do, rather than what someone is telling you that they did for them. So you don't want to record the staff's assessment of the patient's capabilities of performing the activity. You want to get, again, what the patient is doing. So we talked about 2 or more helpers, mean dependent, and then if the patient doesn't attempt the activity and the helper does not complete the activity during the entire assessment period, I'm repeating myself on that one again, ensure that you've looked at all 3 days before you're using the not attempted codes. And to clarify, of course, your own understanding of the patient's performance of the activity, those probing questions, that interview that we talked about in discussing with someone who has observed the patient, those are going to help you to determine and inform you towards what you will code that activity as. And the patient has an incomplete stay, then you'll be skipping the discharge, care, and mobility performance items. Those will not be on your discharge. So let's now talk a little bit about the dash here. So the dash is a value that indicates not assessed. So CMS expects a dash to be used as a rare occurrence. And you don't want to use the dash for the reason that the item was not assessed because of patient refused, not applicable, not attempted due to environmental limitations, or any of those other not attempted codes. So using that 6-point scale or activity not attempted code to code the patient's discharge goals, we talked about this, and how this is now permissible to use those not attempted codes for a goal if you want to. And then for the IRF quality reporting program completion, at least one discharge goal is required for one of the self-care or mobility items. So you can use a dash. It is permissible in the case where any remaining self-care goals, either self-care or mobility goals, were not coded, and that's when you can use a dash. And in this case, the dash is allowed, and it will not affect your APU determination. Licensed clinicians can establish the discharge goals at the time of admission. So you'll be co-creating those. It's important to consider the patient's interest as well here. And then we'll start to look at the GG0130 admission performance and discharge items. Here is the first item, which we'll talk about, eating. So the definition of eating has been clarified. So we now say that the ability to use suitable utensils to bring food or liquid to the mouth and swallow or liquid once the meal is placed before the patient. So we had included liquid before, but now we have stated it in there. So this shouldn't change your codes. So when we're assessing eating and drinking, we're looking at by mouth only. If the patient eats and drinks by mouth and relies partially on obtaining their nutrition through a G-tube or total parenteral nutrition, you want to code the eating items based on the oral activity, not by the other means of total parenteral nutrition. Assistance with a G-tube or TPN is not considered when you're coding the eating item. So we'll first begin our coding with a scenario for our first patient, Mrs. T here. And for the last 2 years, okay, so there's some history here. For the last 2 years, Ms. T has been unable to eat or drink by mouth due to a swallowing disorder and a disorder of aspiration pneumonia, and she uses a G-tube to obtain nutrition. Ms. D had a stroke 8 days ago, and her IRF admission orders included nothing by mouth, NPO with a G-tube. So recall, we're assessing this eating item for eating and drinking by mouth only. She doesn't drink and eat by mouth at the time of the assessment, and she's had this condition for 2 years and continues to require a G-tube. Okay, so think about that before you submit your code here. Okay, so would she be coded 01 dependent, 02 substantial maximal assist, 009, or code 88? Remember what we talked about. So let's see how you're doing with the coding. Aha. Okay. So it looks like we've got a good number of 09s here coming up. And 09 it is, of course. So thank you for listening in terms of the distinction between the 09 and 88. This was a really good example. I gave you a little bit of cue there in terms of it was the history, right, of her having this issue that she could not do this activity historically and then also at the admission. So the rationale, of course, includes that she didn't eat or eat or drink by mouth prior to the current illness or exacerbation, and eating includes only eating by mouth. Okay. So now we're going to look at oral hygiene. This is what it looks like on the assessment. Definition of oral hygiene has been clarified. So we've included more specifically in the definition about dentures, even though this had been included before. So now it says the ability to use suitable items to clean teeth, dentures, if applicable, the ability to insert and remove dentures into and from the mouth, and manage denture soaking and rinsing and use of equipment. So here is our next scenario, Mrs. L. So Mrs. L had a stroke resulting from fine motor and cognitive limitations. At the end of her IRF stay, the OT asked Ms. L to demonstrate her ability to brush her teeth. Ms. L declines because she had already brushed her teeth. But the therapist continued to ask the patient to verify about her oral hygiene care. So she got information from the patient here, and then she went and spoke with the nurse. And the nurse indicated that Mrs. L brushes her teeth at the sink and needs cues to place toothpaste on her brush and verbal reminders to initiate oral hygiene tasks. No physical assistance is required to complete this activity. So your choices are 05, setup or cleanup, 04, supervision or touching assistance, that includes verbal cues as well, code 03, partial moderate assist, and code 02, substantial maximal assist. Let's see what you got. Okay. And let's see. You were right. As expected, supervision, the majority of you said, the supervision or touching assistance for 04. So the rationale, of course, is that the helper provided verbal cues as Ms. L completed the activity of oral hygiene, and she completed the task. While she declined during therapy, it was important to note that this therapist went on to ask the patient and the nurse to find out what actually her performance was. So that's a good thing to keep in mind when you're teaching use of these items. Okay, so now we're going to go to toileting hygiene. And here we have toileting hygiene, which focuses on clothing management and perineal and perianal hygiene. Toileting hygiene is coded if the patient uses a toilet, uses a commode, is incontinent or continent, and completes a bowel program in bed. So that's important to keep in mind. And coding is based on all the tasks that make up the activity. So for toilet hygiene, it includes managing and removing clothing for perineal and perianal hygiene after voiding or a bowel movement, and then replacing, adjusting the clothing, the pants, etc. So this is important to note. You'd have all those details, and then as you see in bold, what we have added here for clarification was voiding or having a bowel movement. So let's go to our scenario, coding scenario 3. So again, you want to think through, there we go. Okay, you want to think through all the tasks for this activity. Removing and managing the clothes, cleansing the perineal and perianal area, and then clothing back up or on the patient. So remember that as we go through this, so that you're thinking through all the different tasks so you can decide what the coding would be. So during the 3-day admission assessment period, Ms. M was incontinent of urine several times and continent of urine once. So she's usually incontinent. That's why we're coding this. When incontinent, Ms. M needed assistance to remove her wet clothing. Mrs. M initiates cleaning her perineal and buttock area, but the certified nursing assistant assists with cleansing for thoroughness and dons Mrs. M's clean underwear and slacks over her feet, ankles, and up her knees. While the helper steadies her, Ms. M pulls up her underwear and slacks only from her knees to her waist. So what would you code here for this item? Would you code 04, supervision or touching? Would you code 03, partial or moderate assist? Would you code 02, substantial, maximal assist? Or code 1, dependent? Okay, looks like code 02 is the resounding choice, and of course that's correct. Excellent. So in this case, the coding was based on the assistance needed to remove her clothing and complete the perineal care and adjust and replace the clothing. And since she's incontinent most of the time, the coding was based on the need while she was incontinent. And she did require help with more than half the effort of the activity, with the removal of the clothing, some help with cleansing, and then again, some help with donning and doffing. So when you take all those tasks and separate them for the activity, then you can see why that was the answer. Okay, let's look at shower and bathing. This was added in terms of excludes washing of back and hair, just for clarification in the definition of the assessment form. So it's the ability to bathe. Self includes washing, rinsing, drying self, excludes washing of back and hair, and does not include transferring in and out of the tub. Our practice scenario 4 is Ms. N declines to shower herself when the occupational therapist attempts to complete the assessment. The therapist asks Ms. N, CNA, to the detailed questions about Ms. N's ability to shower or bathe herself, and considers this information when she's coding the activity. So the therapist learns that Ms. N takes a shower and initiates washing her face, arms, chest, parts of her leg, and perineal area. She requires assistance to wash and rinse and dry only her lower extremities below the knee. That's it. Ms. N rinses and dries most of her body. So the only assistance that she needed was to wash below her knees, and then she washed the rest of herself and rinses and dries most of her body. So how much assistance was needed here? Was it 04, supervision, touching assist, 03, partial moderate assist, 02, substantial maximal assist, or 01, dependent? Excellent. Okay, looks like we've got over 97% that are saying that the correct answer is 03, which it is. And as we saw, that the helper provided less than half the effort as Mrs. N completed the activity, and the therapist does not observe the patient's bathing and asks if the therapist does not observe the patient's bathing, she asks other clinicians and staffs about that ability. So let's look at upper body dressing. So I just want to remind you that that prosthesis and orthosis are counted as pieces of clothing when you're looking at upper body and lower body dressing. Also, the residual limb shrinker would also be considered a part of clothing. So let's look at coding for scenario 5. Mr. T has reduced strength and a range of motion in both upper extremities following spinal surgery, and he wears a cervical collar. The nurse puts on the cervical collar once Mr. T is sitting at the side of the bed, and he threads his hand into the sleeve of his shirt. And due to his no twisting precautions, the nurse pulls the shirt across his back and threads in his other hand into the shirt. The nurse also pulls up the shirt over both shoulders, and Mr. T buttons 2 of his buttons, and the nurse buttons the last 3. So you can list all these things out and look at all the different things here. Remember that the cervical collar is part of considered in terms of dressing. So what would the code be here? Would it be 04, supervision? Would it be 03, partial moderate assist? Or would it be 02, substantial maximal assist? So it looks like we have a vote of more than 98% are saying it is 02. And yes, indeed, substantial maximal assist is it. Excellent job. Okay, for coding of scenario 5, let's look at, for this rationale for what we just coded. Mr. T threaded one arm of his shirt sleeve and buttons up some of his buttons, but of course, as we saw, the nurse assists Mr. T by applying his cervical collar and helping him pull up his shirt around his back, threading the other arm, and pulling it over his shoulder. So for dressing items, consider donning and doffing and orthosis prosthesis. We talked about this. Okay. So lower body dressing, let's see what we have for scenario 6 here. Mr. Z recently underwent surgery for a left below the knee amputation. Mr. Z's leg prosthesis requires the use of a shrinker sock to control edema on the residual limb. He dons and doffs his lower body clothing by lying on the bed and turning himself to get on his underwear and pants and requiring no assistance. Mr. Z has difficulty stretching the shrinker sock over his residual limb and requires the nurse's assistance to lift his residual limb while doffing and donning the shrinker sock. Mr. Z then places his residual limb completely on and into the prosthesis with a small amount of assistance from the nurse. Okay, so what amount of assistance is required here? Was it 05, setup or cleanup? Was it 04, supervision or touching assistance? Was it 03, partial and moderate assistance with the assistance that was given to him? Was it 03 or was it 02, substantial maximal assist? Okay, people are reconsidering and thinking this through. All right, and the majority of you said 03. Okay, so let's see, that was correct. So remember, while we were talking about this, there was discussion of lifting that residual limb and placing assistance on that limb. So that's going to be more than just contact guard assist. Also, he also needed some more assistance in getting on that prosthesis. Again, in total, that's going to be more than contact guard assist. So that's why we have 03, partial moderate assist. So we need to look at all the different elements and look at the amount of assistance and to see if it's more than that little bit of assistance that 04 supervision touching assistance would give. So this is a good one to teach and to practice with your your staff, because it has some nuances that are really important for people to understand. Okay, so here we are with the next item, which is putting on and taking off footwear. And we want you to recall that anything that has to be placed on the foot, such as an ankle foot orthosis, counts as a piece of clothing when adding up all of the tasks that are made up in an activity. And also recall that anything above the knee or below the knee prosthesis would be included for lower body dressing. So those are things that you'll see in the manual, which we have lots of information there for you. And so the definition of putting on and taking off footwear has been clarified. We've included that, which is in bold. It is the ability to take on and off socks and shoes or other footwear that is appropriate for safe mobility, including fasteners if applicable. So let's take a look at this one. Mr. Q underwent bilateral below the knee amputations 3 years ago. He uses bilateral limb prosthesis and attaches shoes and socks that he never changes. He does not change those socks. Prior to the current episode of care at acute care hospital and during the IRF stay, he does not perform the activity of putting on and taking off the footwear. So there's history to this of not doing it, and he does not do it during the stay. So how would you code this item? 01 dependent, 09 not applicable, or code 88, or code 07. Which of these are you going to choose? Great, okay, 100%, wow, excellent. Oh, all right. So next we've got you folks understood this quite well, that with this person with an amputation, the activity of putting on and off footwear may not occur. And in this case, Mr. Q's socks and shoes were attached, so he didn't touch those. And of course, he didn't do this prior to the current illness or exacerbation, which is why, of course, you chose an 09. If a patient has a newly bilateral leg amputation and completes putting on and taking off footwear immediately prior to the current illness, this is where a good distinction is made between 09 and 88. So then it would be applicable to use the code 88 because it was something that was not historically not attempted by him, but this is something new to him. Okay, so let's talk a little bit about self-care discharge goals, and that's that second column there. And we'll give you some tips about that, coding using the 6-point scale or activity not attempted codes to code the patient's discharge goals. And of course, now you are able to use all of these codes, the 0 to 6, as well as the not attempted. Use of a dash to indicate that a specific activity is not a goal. We talked about this before. We just want to remind you that it's acceptable if it's not a goal for the patient. You may use a dash and there's no consequences for the IRF-QRP. One goal must be indicated for either self-care or mobility, so a minimum one, and most of you, thank you, give us more than one. A lot of people have said that they like to show and indicate what it is that those goals are, so we appreciate that. And using the dash is this allowed instance, as far as we mentioned before, is not does not affect the APU. So licensed clinicians can establish the patient's discharge goals at the time of admission based on all of these bullet points. We've got patient's prior medical condition, and it's very important to consider that in terms of how you want to determine your goals. As you know, the prior and current self-care and mobility status is also taken into account because you can see what the differential is from prior status to present status. And then, of course, the very important discussions with your patients and family concerning their discharge goals. It's so important that these are co-created, that your goals are a part of what you and the patient have input in, and if applicable, then the family members too, because they're going to be motivated, right, towards making gains towards those goals if they are a part of that whole process. And then from a professional standard of practice, you would also want to take that perspective in terms of those goals, and then the expected treatments, because knowing that the patient is going to be using a prosthesis, let's say, is an indication of what you might expect in terms of that goal. So whatever the kinds of treatments as well that may be a part of their stay, or as I mentioned, some equipment that may be issued and taught. The patient's motivation to improve, we talked about that a little bit in getting their buy-in in terms of establishing those discharge goals. And then importantly is the patient's planned discharge setting. So if they are going home, of course you're going to, and they will also be motivated towards working towards getting themselves as independent as possible in that environment. And of course what kinds of assistance they may have or not have is an important factor as well. So again, the goals should be co-created and established as part of the patient's care plan. So we often expect in an IRF with our patients that the discharge goal is going to be higher than the admission assessment performance goal. And if that's the case, then the clinician and the patient determine what expected gains, what degree of gains that patient will make. And sometimes there are conditions that the patient has or that is expected that for some of these assessment items that the patient wants to remain at the same level, or it's indicated, and if the clinician and the patient determine that the patient's expected to maintain their same function, which is an important thing, maintaining function is acceptable in terms of a goal for a patient as well. And it's not anticipated for that patient to gain in terms of progress for an activity. So I leave us there at this point because Ann Deitch will be coming back after our break to go over the mobility items with you. And I thank you so much for your listening and also applaud you folks as far as the great work that you do in the field with the patients. Thank you.
All right, thanks everybody. Carol gave a great overview of the rating scale. She went over the self-care activities with you. I'm just picking off where Carol left off, talking about mobility. So I will reinforce some of the things that Carol talked about and also build on what Chris Gross talked about this morning in terms of some of the changes. So in terms of the mobility items, these are all, I'm sure, familiar to you because they've been on the IRF-PAI since October 1, 2016. And we'll be going through each of them, talking about updates and, again, many examples. These are the remainder of the items. As you can see, this is the admission form. So there's the admission performance section, and then the second column is goal. As you know, there's follow-up questions related to the wheelchair items, and so there's kind of that highlighted area at the bottom of the screen there for those items. So the first activity that is included in the mobility section covers some bed mobility, and specifically this one is about roll left and right. So this particular activity is defined as the ability to roll from lying to the back and right side and return to lying on the back of the bed. And there was some wording clarification done here. So as Carol mentioned in her presentation, some of the definitions have been clarified, and that's again because we had many help desk questions over the last couple of years across inpatient rehab facilities as well as long-term care hospitals and skilled nursing facilities, and we wanted the definitions to be as clear as possible so that you didn't have to guess about some of the was this included or was that included, and so some of these these definitions, clarifications are really just to make sure everybody has the same information. So coding for the 2016 data set versus the 2018 data set is not different for this item in any way. Again, the wording is just to clarify. So again, the last part of the definition was clarified on the bed. And again, we had questions specifically about this particular item where the clinicians were asking whether a assessment for this particular item could be done on a mat, and our response was no, it needs to be done on a bed. So some of the scenarios that we have for you today reinforce some of the questions that have been submitted, and so these are new examples. They're not in the IRF-PAI manual for the most part, and as Carol indicated, we wanted to take this opportunity to share with you some of what your colleagues have asked through Help Desk. And so that's why we're bringing up some of these topics, because we wanted to be sure to reinforce this information. So the scenario 8, which is the first one in the mobility section, asks about Ms. W's head of the bed must remain slightly elevated at all times due to aspiration precautions. Although the head of the bed is slightly elevated, the therapist determines that she can assess Ms. W's ability to roll left and right. The therapist provides verbal instructions as Ms. W completes the activity. And I'm not sure if Carol mentioned this, but you do have all of these scenarios in your packet. So if you wanted to look at them or write notes on them as we're going through them, please feel free to pull that out. And we will be obviously going through the answers just like Carol did. The slides will be posted with the responses at a later date, so you will have all of the slides at a later time on the website. So what we wanted to emphasize in this particular example is about the head of the bed being slightly up. So we've had many questions over the last couple of years about, can you code the bed mobility items when somebody's head of the bed is slightly elevated, or if the head of the bed is elevated, or if the person actually sleeps in an upright chair? And so our response is that you use clinical judgment. If the head of the bed is slightly elevated and you believe that you can do an assessment of this activity, then yes, go ahead and do the assessment. If the head of the bed is so elevated or the person is in a chair that you don't feel you can do an assessment of the person's bed mobility activities, then this particular item could be marked 88 or 09, depending on the person's situation. So again, it's clinical judgment. In this case, in this example, it says, although the head of the bed is slightly elevated, the therapist determines that she can assess Ms. W's ability to roll left and right. And so in this case, you would be able to score, and you would be coding using the 6-level rating scale. So in this case, it's verbal instructions. And so if you think through the rating scale decision trees that Carol talked about earlier. So the first question you'd ask yourself is, does the person need help? And of course, in this case, the answer is yes. Is it just setup assistance? And the answer is no to that. So then you'd say, is it just verbal supervision or studying assistance, touching assistance? And if the answer is yes, what score would you go for that? I'll let you pull out your phones and put your answers. Would you code this particular example where there's verbal instructions being provided? Would you code that a 5, a 4, a 9, or an 88? Okay, looks like 100% of you coded 04, which is indeed the correct response. And so I will now go to the rationale here, which is indeed a code 4. The next activity here that we're going to talk about is sit to lying. So again, another area of bed mobility. And this refers to the ability to move from sitting on the side of the bed to having the lying flat on the bed. So in this scenario, 9, in this case, Mr. K is our patient, and he is admitted to the IRF following a left knee replacement and presents with mild cognitive deficits. The occupational therapist provides verbal and nonverbal cueing in order for Mr. K to scoot into the center of the bed to safely transition from a sitting to a lying position. Mr. K completes most of the activity, but needs assistance from the therapist to lift his left leg into the bed. So again, thinking through the decision trees, you would think, okay, does the person need help? The answer is yes in this case. Next question, is it just setup assistance? In this case, it's more than that. And so the next question is whether there's just supervision or instruction, verbal cueing, or touching, steadying assistance. If the answer is no, and in this case, I would say it's more than touching, because in this case, it says in the last bullet that the therapist lifts the patient, Mr. K's, left leg onto the bed. So once we get into lifting assistance being provided, it's going to be a code 3 or below. And so the judgment that needs to be made at this point is whether the patient is doing more than half of the effort or the helper is doing more than half of the effort. If the patient is doing more than half of the effort, it would be coded 3. If the helper is doing more than half the effort and the patient is doing less than half of the effort, it would be coded 2. And then, of course, dependent, the patient performs, the helper's helping the patient perform the activity completely. So in this case, it says that Mr. K scoots to the center of the bed and transitions from sitting to lying, and that the therapist is actually lifting the leg. So how would you code 0170B, this bed mobility item? Would you code it 05? Would you code it 4? Would you code it 3? Or would you code it 2? Okay, it looks like most of you are coding code 3, and I do agree that is the correct response. And the rationale is that indeed there's lifting assistance. And we do have a note here, and again, this is not on your current slides that are posted, but this will be posted after this training, so you will have access to this in the future. And we have this note here that the bed mobility items should be assessed on a bed, not on a raised mat or a reclining chair, and this refers to all the bed mobility items. So that's item 0170A, B, C. Okay, so moving on to item C, that's lying to sitting on the side of the bed. And in this particular item, the activity is defined as the ability to move from lying on the back to sitting on the side of the bed with the feet flat on the floor with no back support. So we've had many questions about this one that seem to focus mainly on the issue of does the patient need to have feet flat on the floor? And so we have an example here where there's some clinical judgment that's made where the person actually has had bilateral above the knee amputations, and so that doesn't apply to this person. And so that is acceptable to code for this person based on what completing the activity means for this individual patient. So let's talk through the example. In this case, Mrs. A recently had bilateral above the knee amputations and is now admitted to the IRF for intensive rehabilitation as she learns to walk with her prostheses. Upon rising in the morning, Mrs. A does not wear her prosthesis. The CNA steadies her as she rolls to the side of the bed. When Miss A raises herself from lying into a sitting position, the helper provides steadying assistance to help her get from a lying position to a sitting position. So in this case, the person is not able to put their feet flat on the floor, but they basically have completed the activity for what they need to do. And so you can code based on this information. So again, just to walk through to the decision trees. So in this case, you'd ask yourself, does the person need help? And it says that Miss A raises herself from lying to a sitting position. The helper provides steadying assistance. So there is help being provided. You would then ask, is it just setup assistance? And if the answer is no, which in this case is no, you'd move down to ask the next question, which is whether there's touching or supervision assistance being provided, and in this case, it's steadying assistance. There's no indication of any lifting assistance being provided, so it seems like that is where we can stop with the decision tree questions. So based on that and this example, how would you code this patient? So code options are 5, 4, 3, and 2. I'll just give you a minute here. Looks like most of you are coding a 4, okay? And that is the correct response. So steadying assistance is coded 4. The next activity is sit to stand. Sit to stand refers to the ability to come to a standing position from sitting in a chair, a wheelchair, or perhaps on the side of the bed. So in this example, we have a patient, Miss P, who is morbidly obese and has severe arthritis in both knees. She's unable to transition from a sit to stand without the use of a mechanical lift. Mrs. P lifts and places her feet on a standing lift device to initiate the activity. Assistance from 2 helpers is required as Miss P is helped to transition from a sitting to a standing position. So this example was actually inspired by some questions that we've had about whether to code a 1 or a 2 in the event where the patient is doing some of the activity. And so, the clinician would like to give the person credit for being able to do some of the activity, but then we have this rule that when 2 helpers are required, you would code 1. And so if you actually go through the decision trees that Carol reviewed earlier before the break, one of the things that you'll notice is that we say, does the person require assistance, for example, setup from 1 helper? Does the person require steadying supervision assistance from 1 helper? And if you followed the decision trees, if only 1 helper is providing assistance for this person, you would code 2, but if 2 people are providing the assistance to the patient, regardless of what the patient is doing, you would actually code 1. So with that in mind, I've given you a major cue there, but with that in mind, it says that 2 helpers are required for Ms. P to get from the sitting to the standing position. So again, I'll give you the opportunity to put the answers into your phone. The options are code 2, code 1, 9 not applicable, and 88 not attempted due to medical condition and safety concern. Okay, great. So it looks like most of you did code 1, which is indeed the correct response. And again, the rationale is that if 2 or more helpers are required, it would be a level 1, even if the patient is providing a little bit of effort to make the activity occur. And again, if you follow the decision trees do help you get to the right response here. Okay, moving on to the next activity, which is E, bed to chair transfer. In this case, we have the definition being the ability to transfer to and from a bed, chair, or from a bed into a wheelchair. For this example, we have Mr. L, who has spinal stenosis, and due to back pain, he's not able to fully stand up. And so he uses a stand pivot, basically when he's getting from a chair to bed or from his bed into a chair. And that's during the 3-day assessment period. The occupational therapist uses a gait belt around Mr. L's waist, providing initial lift assistance from the chair bed as he raises himself to a stooped over position. So again, he's because of pain, he's not fully standing, but that's okay. You code him based on what he's actually doing. The therapist continues to steady him as he completes a pivot, turns, and then lowers himself into the chair. Mr. L contributes more than half of the effort. So in this case, you'd go through the decision trees thinking about whether help is being provided, yes, and then is it just setup assistance, no. So the next question is whether it's just supervision or steadying, touching assistance. In this case, it's more than that. And so then the question then becomes, if there's lifting assistance, is the patient performing more than half of the effort or less than half of the effort? More than half of the effort would be coded 3, and less than half of the effort would be by the patient would be coded a 2. So in this case, please pull out your phones and you have the options of responding 04, 03, 02, or 01. So, okay. Looks like most people are coding 03, partial moderate assistance, and I do agree with that response. That is the correct response. And the rationale, again, being that the patient is performing more than half of the effort, but there is lifting assistance, and therefore it is coded a level 3. The next activity is toilet transfer, and this refers to the ability to get on and off a toilet or commode. And so we have an example, Mr. B. Mr. B uses a raised toilet seat on his toilet. Although Mr. B completes the transfers to and from the toilet without physical assistance, he is impulsive and requires a nurse to provide verbal cues to remind him of safe transfer strategies to avoid falling. So the rating scale does take into account any cueing that's needed, regardless of why the cueing is needed, in order to keep the patient safe. And so in this case, again, you'd go through the decision tree, so there is help provided. It's more than just setup or cleanup. And so then the question is it just supervision, cueing, touching assistance? And in this case, it does seem that that is what is happening here. So I'll let you pull out your phones and put in a response. The options here are code 5, which is setup cleanup, 4, supervision or touching assistance, 3, partial moderate assistance, and code 2, substantial assistance. Look like everybody coded 04, and I do agree with that. So again, the rationale, as you figured out, is that regardless of why the person needs cueing or supervision, the code would be supervision or coding, for coding. Okay, moving on to car transfers. So car transfers refers to the ability to transfer in and out of a car or van on the passenger side. It does not include the ability to open and close the door or fasten seatbelts. So it's just really the activity of getting into and out of the passenger seat. So in coding scenario 14, we have an example, Mr. T. So when performing car transfers, Mr. T, who recently had hip surgery, requires significant support from the physical therapist as he transitions into the passenger seat of the car to maintain his hip precautions. So again, as Carol mentioned, we're always concerned about safety, so that's always taken into consideration. Once seated, Mr. T places his left leg into the car and requires assistance to lift his right leg into the car. When transferring out of the car, Mr. T requires significant lifting assistance. So again, he required that assistance getting into the car and getting out of the car. And the therapist lifts his right leg out of the car. Mr. T lifts his left leg out of the car. So as we go through this example, we are going to, again, talk through the decision tree. So the first question would be, does he need help? The answer is yes. Is it just setup assistance? No, it's more than setup assistance. So then the question is it touching assistance or supervision or cueing, or is it more? In this case, it's more. So then the next question becomes, is the patient able to do more than half of the effort and be coded 3, or is the helper doing more than half of the effort, meaning that the patient is doing less than half of the effort? That would be coded 2. And if the person is not able to help at all with performing the activity, that would be coded 1. So in this case, it says that there's significant lifting that's being provided by the therapist. The patient is lifting one of his legs in and out of the car, but the helper is lifting one of his legs in and out of the car also. So I'll let you pull out your phones and code this example. The options are code 5, code 4, code 3, or code 2. So it looks like most people are coding 2, a couple of people coding 3. So in this case, the significant lifting and the fact that the therapist also lifted his leg was meant to suggest that the patient was actually doing less than half of the effort, and so that is coded 2. Okay, the next activity that we're going to be talking through is walking 10 feet. So I believe you're aware that there's several activities related to walking. And over the last couple of years, we have had quite a few questions about instances where, let's say, a patient is able to walk 5 feet or 8 feet, but they're not able to walk the entire distance. And because a patient, if they're not able to walk that full distance, nobody is actually helping them to complete the activity. You would code that the activity did not occur if the person is not able to walk the entire distance. So obviously, 150 feet is one of the more commonly coded items where this would apply. So if somebody can walk 120 feet, but not 150 feet, you would indicate in your code that the activity did not occur. So we do have a few examples, and so we'll talk through that. I guess the other thing I wanted to mention is that we have updated the IRF-PAI manual. I think it got posted yesterday, so probably many of you have not seen it yet. But based on all the great help desk questions that you've submitted to CMS, we have created coding tips for most, if not all, of the items, and those are now in the updated IRF-PAI manual effective October 1, 2018. So you can certainly find a lot of the coding tips and examples that I'm talking through as part of this presentation. You'll find those in the manual. So let me just walk through the definition here. So in this case, it refers to the ability to walk at least 10 feet in a room, corridor, or similar space. The assessment would start once the person is in a standing position. So obviously we've already talked about the transfers being coded separately. And so this is really once the person's in a standing position, are they able to walk 10 feet? One of the important things that I wanted to be sure that we talked about is that there is a skip pattern associated with this item. So if you indicate that the person does not walk, does not perform the activity didn't occur. So it could be a code 9, 10, 7, or 88. There's a skip pattern because we know that if somebody is not able to walk 10 feet, they wouldn't be able to walk the 50 feet or 150 feet. And so we've tried to reduce burden by having a skip pattern. So one of the things that happened with this particular data set, actually all of the 2018 data sets, is that the actual gateway question, which was did the person walk, was removed and the skip pattern was embedded in this 10 feet item. So you'll notice there's one less item basically, and so this walk 10 feet item basically serves as both an assessment item as well as a gateway question to the next items. Okay, so we have an example here, coding scenario 15. Mrs. L has severe rheumatoid arthritis and balance difficulties. Prior to her current illness, she walked short distances with contact guard. During therapy, she declined to walk on day 1 and day 2 of the 3-day assessment period. On the 3rd day, she walked 7 feet with the assistance of 2 helpers in therapy. The physical therapist seeks input from the multidisciplinary team of clinicians caring for Mrs. L during the assessment period. So the therapist in this case is thinking, okay, I'm supposed to be assessing 10 feet. In therapy, the person is walking 7 feet, but not 10 feet. And so she has not, as a therapist, or he has not observed the person walking 10 feet. And so she's going to check with the other staff. Maybe the patient actually has walked 10 feet or more on the unit. So it says in the next bullet, for coding, the physical therapist considers direct observation and reports by the patient and provided by other care staff to state that Ms. L did not walk at least 10 feet during the 3-day assessment period. So in this case, you'll be coding one of the activity not attempted codes. And so as you know, there's options that the patient refused. There's an option that, which is 07. There's the option that the patient did not do the activity currently at the time of assessment and did not do it prior to the current illness, exacerbation, or injury. That's 09. And there's the option that the person cannot perform the activity due to their recent onset medical condition, which would be 88, and then the code 10, which refers to environmental limitations. So in this case, the first bullet is relevant. It says that she has had severe rheumatoid arthritis and balance difficulties. Prior to her current illness, she walked short distances with contact guard assistance. So in this case, she did walk prior to her current illness, exacerbation, or injury. So we'll consider short distances to be 10 or more. And so basically, because this patient was not able to walk the 10 feet distance, so she walked 7 feet, she did not walk 10 feet, you would say the activity didn't occur, and I will let you pull that information together to determine which code would be appropriate. So one option for coding is 1, dependent. So in order to be coded dependent, the person or the activity does need to occur. A code 1 would mean that the helper did all the effort for the patient. A code 9, not applicable, takes into account somebody was not doing the activity prior to the current illness, exacerbation, or injury. Code 88, which most of you are coded, is the case where the person cannot do it because of illness or injury. And code 7 is patient refused. So it looks like a few people did code 07. The correct response is 88, which most people did code. And this is actually a great example. In the case where somebody declines to perform an activity, the clinician needs to make a judgment whether the person is declining for medical reasons. So if somebody says, you know, I just don't feel like I can do it because I'm in a lot of pain, certainly that's a medical condition, a pain. So usually we wouldn't expect patient refusal to be used commonly as a code. And basically the intent is that it really is the clinician believes the patient could perform the activity. There's no medical reason why the person wouldn't perform the activity, but they're declining or refusing to do it. So in this case, the correct code is 88. So our rationale is that the patient would be coded 88 because she does not walk, again, the 10 feet, as I mentioned previously. She did walk short distances prior, which is the second bullet. Again, you would not code 07 in this instance because she did actually have, you know, rheumatoid arthritis and was in a lot of pain, and that's why she didn't want to push herself. So 88 is still appropriate in that instance. I think we do have another example focused on this, so you'll have a bit more opportunity to with another example. Okay, so the next activity refers to walking 50 feet with 2 turns, and this is defined as once standing, the ability to walk at least 50 feet and make 2 turns. So we have an example here where Mrs. S has multiple sclerosis and has lower extremity weakness as a part of her condition. She uses a rolling walker for short distances at home and has not walked more than 30 feet in 2 years. When traveling distances of more than 30 feet, she uses an electric scooter. Ms. S. did not walk 50 feet with 2 turns during the IRF admission assessment. So the IRF admission assessment is a 3-day period. It says she uses a wheelchair to go distances of more than 30 feet. We're coding walking in this instance, not wheelchairs, so we'll come to the wheelchair items later on. But in terms of walking, it says she did not do the activity. And so in this case, again, if the person doesn't go the distance for the particular item, and in this case it's 50 feet, she did not go 50 feet, we would say the activity didn't occur. And so now you need to think through what was her status prior to her current illness, exacerbation, or injury. So again, if somebody was not performing the activity prior to the current illness, exacerbation, or injury and does not perform it at the time of the assessment, you would code 09. If the person was performing the activity prior to the current illness, exacerbation, or injury, does not do it on admission due to, or discharge due to a recent onset illness, injury, or exacerbation, that would be coded 88. So I will give you the opportunity to code what you believe is the correct response. In this case, the options are 02, 01, 09, or 88. And it looks like 90+% are coding 09. And I do agree with the coding of 09. In this case, it said that she had not been walking prior to her current illness, exacerbation, or injury. And just, I guess, I did notice a few people coded 88, maybe just to clarify. So if somebody has a chronic condition that, so perhaps a spinal cord injury or multiple sclerosis or Parkinson's disease, we consider prior to the current illness, exacerbation, or injury basically being triggered by a acute care hospital stay, or maybe in this case the person got directly admitted to the IRF, but it's basically this episode of care. So the fact that this, in the example I think we said 2 years, she had not been walking in 2 years, so that would be prior to an exacerbation in this case, as opposed to her multiple sclerosis diagnosis. So I hope that helps clarify that issue. So again, when you're coding 09 versus 88, it would be based on the current episode of care. So if somebody goes from, let's say, acute care into an IRF, it would be the person's status that immediately prior to the acute care stay. Or if the person got admitted directly to the IRF, it would be the person's status immediately before the IRF admission. Okay, so this is just a rationale, and again, this will be posted on the website. Okay, the next activity is walk 150 feet. So this particular item, again, begins once the person is starting from a standing position, and it refers to the ability to walk at least 150 feet in a corridor or similar place. So we've got a bit more complex example here. So Ms. B has diabetes, spinal stenosis, and a surgical amputation below the knee. Ms. B uses a prosthesis but complains of soreness at the distal end of the residual limb and informs the nurse. Complaints of pain result in her declining to walk 150 feet, and I think this is actually meant to be during the 3-day assessment period, so I apologize. It looks like there's, and the wrong word is there, but basically it says it's meant to say she declines to walk during the 3-day assessment period. The therapist asked Ms. B and relevant staff if Ms. B walked 150 feet on the unit, but the staff reports she only walks short distances, less than 150 feet. So in this instance, so again, this person is having pain, and so that means that she's actually declining to walk in therapy because the therapist knows that It's the kind of team effort that's important to consider when coding all of the Section GG items. And so she asked the staff on the nursing care unit if the person is walking, and they say she is not walking. So in this case, the activity is not occurring. So again, this is another example where the person has declined, but there is a reason. She is having pain, and she just experienced a surgical amputation, so that is not surprising that she might have some pain and that she's not able to actually walk at this point in time. So in this case, how would you code this particular person? So the options that you can enter into your phone are 01, dependent, 09, not applicable, 88, not attempted due to medical condition or safety concern, and 07, patient refused. Okay, it looks like 100% of you did code 88, so that's great. So again, this is just reinforcement that if somebody has a legitimate medical issue such as pain, we wouldn't code them refused. So again, 88, and here's the rationale. And in this instance, in the rationale, we do kind of spell out that you would not code it patient refused because the patient did have pain. Okay, the next activity is walking 10 feet on uneven surfaces. And so we have, as the definition here, the ability to walk 10 feet on uneven or sloping surfaces, indoor or outdoor, such as turf or gravel. So there was a slight update in the definition. Again, we had quite a few questions on the help desk about this particular item. What do you mean by uneven surfaces? It is possible that you can take a patient outside to practice this. Certainly we've had lots of people who submitted questions about that, and if you have some kind of garden area, that is certainly appropriate to assess this item in that environment. We also had people who asked a lot of questions about whether there could be kind of an internal obstacle course. I know that some IRFs do provide that for patients because they know that they'll be facing walking up and down busy streets, things like that. And so they need to be able to maintain their balance even under that environment. And so, again, we've just updated the definition so that everybody can benefit from those great questions that have been submitted. And so it now reads in the 2018 data set, the ability to walk 10 feet on uneven or sloping surfaces, indoor or outdoor, such as turf or gravel. Again, you can certainly code now, thinking about this. There's no change in the intent. We just clarified for the sake of making sure that everybody is getting the benefit of all the help desk questions that we've had asked. Okay, so we have another coding scenario here, number 18. So Mr. Z has severe rheumatoid arthritis and has a history of falls. The physical therapist plans to use an outdoor gravel surface to assess Mr. Z's ability to walk 10 feet on an uneven surface. Unexpected severe rain, then snow, occur during all 3 days of the assessment period. The therapist is unsuccessful in locating an indoor uneven surface. Walking 10 feet on uneven surface is not completed during the assessment period. So in this case, there was an intent, but because of weather, and this actually, we do get many questions where people say, how do you code this? And so if you can pull out your phones, the options that you have to code are code 10, not attempted due to environmental limitations, code 9, not applicable, code 88, not attempted due to medical condition or safety concerns, and 07, patient refused. All right, looks like 100% of you coded 10. That is correct. And just, again, this is effective with the October 1, 2018 data set. If this is something, hopefully you don't have snow before then, but in the event that you do, we've told people to code 09 up until October 1, 2018 when this code 10 is available. So just so you kind of know what to do up until then. We put this example in here because Carol and I did want to be sure that you had an example of a code 10 being used. probably most items, the Code 10 would not be applicable, but certainly Code 10 for this particular item is one where we expect it to be used. Another one where we've had lots of questions where we expect it might be used is related to car transfers. But with car transfers, certainly, a discharge, if somebody is being discharged and the family, brings their car on, the day before the person's being discharged or the day of discharge, and there's training that's going on, an assessment of the person's ability to get in and out of the patient's car, that can be done. So we hope that there's not a lot of the use of Code 10, but certainly understand that there are circumstances where that would be coded. So this is just a rationale that, obviously the weather in this case is environmental limitations. Okay, the next activity is one step. And in this case, we are defining that as the ability to go up and down one curb and or one step. There is a skip pattern associated with this particular item. Again, the logic being that if a person is not able to go up and down one step, that person is likely not able to go up and down 4 steps, which is the next item, or the 12 steps, which is the item after that. And so there has been refinement of the language here, basically to say go up and down a curb and or up and down a step. If somebody is using a wheelchair for mobility and they go up and down a curb in their wheelchair, certainly that can be coded with one step. And so again, just the code would be based on how much assistance the person needs to go up and down the one step, whether it's using their feet or perhaps in a wheelchair. And I mentioned the skip pattern, so specifically, if the patient's admission performance score is that the activity did not occur, which is a code 7, 9, 10, or 88, starting October 1, 2018, you would skip over to the pickup object item. Okay, so we have an example. Mr. A has ataxia due to a neurologic condition. He uses a quad cane while walking. When stepping down an outdoor curb, Mr. A steps down as a physical therapist provides significant trunk support to help Mr. A maintain his balance. So significant trunk support, think about the therapist definitely providing a fair bit of assistance. The patient is doing some of the effort, but the therapist is doing a lot of the effort. When stepping up the curb, Mr. A requires a significant amount of trunk support from the therapist also. Mr. A contributes effort, the helper provides more than half of the effort. So I will let you enter your responses into your phones. The options for coding this particular example are code 4, supervision touching assistance, 3, partial moderate assistance, 2, substantial maximal assistance, and code 1, dependent. It looks like 100% of you coded this 2, which I agree with the code 2. And as you, I'm sure, figured out, the patient does less than half of the effort, but does provide some effort. And so that's a code 2. 4 steps is the next activity, and this refers to the ability to go up and down 4 steps with or without a railing. As with the prior item, if somebody is not able to go up and down 4 steps, we assume that they cannot go up and down 12 steps, and so there is a skip pattern. In this case, you're just skipping over one activity. So again, it's the code 7, 9, 10, and 88 that would trigger the skip pattern. So we have another example. In this case, 4 steps. Mr. F is recovering from lower extremity fractures and wears a walking boot and uses a quad cane. Mr. F slowly ascends the stairs, grasping the stair railing with one hand and the quad cane in his other hand. The therapist provides intermittent steadying assistance as he climbs up the 4 steps. He then turns around and requires steadying assistance throughout the activity as he goes down 4 steps. So one of the things that we wanted to highlight in this example, and again, this is triggered by one of your help desk questions. If steadying assistance is provided intermittently or throughout the activity, it's still considered steadying assistance. It's coded the same way with the 04 code. So intermittent versus continual steadying assistance, or intermittent cueing versus constant cueing, they would all be coded a code 4. So in this case, it says intermittent steadying as he climbs up, and then steadying assistance throughout as he goes down. So I will let you code this one on your phone. The options that you have for coding are 05, 04, 3, and 2. And it looks like 100% of you are coding 04, and I do agree with that response. And so you will get that check mark there, and the rationale, as you figured out, is that it's steadying assistance. Okay, the next activity is 12 steps, and in this case, the patient would be assessed looking at their ability to go up and down 12 steps with or without a railing. So in this case, Mr. B is receiving rehabilitation following a hip fracture. Her home has 12 steps with an entry level to the second floor. During the discharge assessment, so we're moving on to discharge, so hopefully she's doing well, Mrs. B uses a cane and the stair railing to ascend 12 steps. And she goes up the steps one step at a time. The physical therapist provides contact guard assistance following behind Mrs. B. When Mrs. B descends the stairs, the therapist provides contact guard assistance and holds Mrs. B's gait belt to steady her. So in this case, the patient is going up the stairs with the therapist behind her, seems to be doing fairly well. Going down, there is a gait belt on, but it sounds like there's still just steadying assistance being provided. And so again, if we talk through those decision trees, does the person need help? Yes. Is it more than just setup? Yes. Is it steadying assistance or more? It seems like they're saying that it's steadying assistance. In this case, the words contact guard are used, which means the same thing. So I will let you pull out your phones and put the responses in. The options are 05, 04, 3, and 2. Okay, looks like 100% of you coded 04. I do agree with that response. And, And our rationale is here. Again, contact guard is equivalent to touching assistance, and so that would be coded 04. Okay, the next activity is picking up an object. That refers to the ability to bend, stoop from a standing position to pick up a small object, such as a spoon, from the floor. What I'd like to emphasize here is that the person does need to be in a standing position as they pick up the object. And so if the person does not stand up, so perhaps at the time of admission, the person is using a wheelchair and does not stand, and so this cannot be assessed because it's not safe for the person. Perhaps their balance is very poor at the point of admission, and so you would code that the activity didn't occur. So again, the person needs to be in a standing position to be able to assess on this particular item. Okay, so we do have a coding scenario, number 22, and in this case, Mr. M has Parkinson's disease and is deconditioned following a recent acute illness and an acute care stay. Mr. M's tremors cause him to drop objects onto the floor frequently. He is highly motivated to perform the activity of picking up a spoon from the floor safely. The spoon is on the floor next to the chair. Mr. M bends to pick up the spoon from the floor, and the therapist provides steadying support to prevent him from falling down as he completes the activity. So, a spoon is certainly one example. I know I think it was during one of our expert panel sessions, some of the clinicians were mentoring people drop their phones all the time at the hospital, and so one of the most frequently tested objects was picking up their cell phone off the floor. In this case, it happens to be a spoon. So this would be coded again based on the amount of assistance being provided by the therapist. It says that it's steadying assistance, and that's for safety reasons because the patient, we obviously don't want this gentleman to fall. And so if you can enter the code that you believe is the correct response, the options are 3, partial moderate assistance, supervision touching assistance, 9, not applicable, 8, not attempted due to medical condition or safety concern. Looks like 100% of you did code 4, which is correct. And so there is the check mark, and the rationale, which you figured out, relates to the steadying assistance. The next question is a gateway question asking about wheelchair and or scooter. And so it says, does the patient use a wheelchair and or scooter? And the options here are no and yes. We do get a fair number of questions about this, so we did put a lot of coding tips into the manual focused on this. I think the bottom line is that if the patient basically is just transported in a wheelchair to therapy, maybe because therapy's on a different floor, or maybe they're going to several tests during the day, or maybe going to dialysis, and so they are pushed in a wheelchair for transport purposes because it's a different department or a different floor, you would not consider that the person using a wheelchair. Examples where you definitely would be coding wheelchair would be that the person, let's say, was using a wheelchair prior to admission, and so they're just continuing to use a wheelchair. That would certainly be appropriate to assess that patient on their wheelchair mobility skills or their scooter, if they use a scooter. Another example is if the treatment plan does include learning how to use a wheelchair as part of therapy, so wheelchair skills training. I know there's a lot of research that's being done in that area at this point in time. So I see a lot of publications about that, how to best teach wheelchair skills. So those patients definitely would be included in terms of assessment for wheelchair. It may be that somebody is admitted and maybe is not able to walk much, and so they're in a wheelchair, maybe on admission. They're mainly being pushed because they, let's say, have severe limitations, perhaps somebody with who's had a stroke and has some neglect. And so maybe somebody has the idea that they might be walking by discharge, but let's say the care plan ends up being updated, and so then wheelchair becomes actually part of their care plan. It's okay to code wheelchair at discharge, but not at admission. So I know we've had questions about that. In the example I gave where the person wasn't walking and they were using a wheelchair on admission, I would code that on admission and say the person was dependent. And then obviously if their care plan changed and they were learning how to use a wheelchair, how to mobilize in a wheelchair at discharge, I would obviously code that also and say they were using a wheelchair. So there is some clinical judgment. Certainly, you know, if you would like to code because you're not sure, you're more than welcome to code this wheelchair item, but I'm just trying to give you examples where you don't need to code, because as I look at the data that's come in, I think, you know, it's possible that there may be a bit of coding where it's being used for transport. So I just wanted to be sure I talked about that today. If somebody does not use a wheelchair and you're coding that the person does not use a wheelchair, you do skip out of the rest of the wheelchair items. And so again, that's why I wanted to give these examples where if it's just transport, just code no, and then you can skip out of the rest of the items. So in the event that somebody does use a wheelchair, we have 2 distances. So wheel 50 feet with 2 turns is one of the items, and that refers to the person's ability to maneuver 50 feet and making 2 turns. It begins once the person is sitting in the wheelchair. We do have an example. Ms. T uses an electric scooter to self-mobilize. In Ms. T's medical record, multiple clinicians note that she needs supervision and verbal instructions for redirection when using her scooter. The physical therapist observes that Ms. T's scooter becomes wedged in a corner as she self-mobilizes approximately 60 feet with 2 turns, the distance from her room to the dining room, and that she requires instructions. So in this case, you have the same information from the clinicians working with her on the unit and the physical therapist. And so I will let you code that particular example. Options are 06, independent, 05, setup or cleanup assistance, code 4, supervision, code 3, partial moderate assistance. Okay, it looks like many people are coding 04, supervision, touching assistance. So yeah, the verbal instructions that were provided both on the unit and by the physical therapist would mean that it's a code 4. That is correct. Code 5 is only for setup or supervision. Okay, there are follow-up questions for both of the wheelchair distances. We did get a question actually in the LTAC training about this, so I will address this now. There was a question about why the type of wheelchair is asked twice, and the rationale is that it's possible that for short distances, such as 50 feet, that the patient uses one type of wheelchair, and that for longer distances, the person uses a different type of wheelchair. And so that's important information that may vary depending on the distance. So the second distance is the wheeling 150 feet. So in this instance, again, it begins once the person is in a seated position and refers to the ability to go 150 feet in a corridor or similar space. The example here, scenario 24, Mr. W is recovering from a stroke and has right-sided weakness that affects his balance and his chronic respiratory condition that affects his walking endurance. By discharge, Mr. W slowly wheels a manual wheelchair 160 feet down the hall without any assistance from a helper. So there's no timing that we're concerned about. In this case, it says that he does not need any help, so I will let you code that. And the options here for coding are 04, 07, 88, and 06. And this, yes, 100% of you are, somebody coded 4. So actually this person's independent, he does not need any help. I do agree with that response, which is what most people coded. And this was our last example. We thought it'd be good to have somebody independent after their IRF stay at the time of discharge. So, all right, so, and there's the rationale, and again, most of you did get that right. He did not need any help. No concern that maybe it takes him a little bit longer to do that activity. I did want to touch on goals just very slightly. I know Carol did a great job covering this. There were a few questions that I did see coming in, so I did want to clarify that for the function process measure. So as part of the IRF-QRP, there is a requirement that at least one self-care or mobility goal is reported in the goal column. If you choose to report more, that is terrific. I know CMS encourages people to put goals for all of the areas. Again, these are co-created goals with the patient, and so you know, if your care plan addresses all of the mobility activities and you choose to code all of the goals, that's terrific. We know there's clinical judgment involved in that, and I thought Carol did a great job talking through that process. So again, if there's more questions, we're happy to address those later today, but hopefully that at least addresses some of the questions. For the next 15 minutes that I have left, I did want to talk a little bit about the functional outcome measures because those reports are now available, and as I think Tree did a nice job presenting yesterday, there's more information available on those reports as time goes on, and so we wanted to be sure that you knew how to interpret those reports. So at this point, these are in your slides, and I will also, as part of this presentation, give you a little bit more information about other resources that are available that are that have a lot of detail and I think will be really helpful for you as you start looking at your data, if you have not already started looking at your data. So just an overview of this last 15 minutes of my presentation. We'll be talking about the key components of a quality measure. We'll be talking about resources, and we'll be talking about how to interpret your data. So what I wanted to convey here in this key components of quality measures is that as part of this training, we spent a lot of time talking about the data elements and collecting data. Once that data is submitted to CMS, there's a lot of analysis that happens in order to calculate the quality measures. So again, very important, obviously, that the data are correct, but I want to be sure that you also understand what happens to that data once it's submitted. So there are many steps that happened, and as part of the work, there's a lot of development work that happens once the measures are developed and are proposed and adopted into the quality reporting programs. The specifications, the quality measure specifications, are shared as part of the rulemaking process. That information is also put into a quality measure user's manual, and again, I'll give you the link to that later on. So all of this information is put in detail in there, but I wanted to give you kind of the highlights and talk generally about it so you know what to look for in that manual. So again, the data elements obviously are key because that allows the right, accurate data to be analyzed. Another step that happens when there's calculation of quality measures is that the population needs to be defined. So who does this quality measure apply to? And so there are terms like denominator or eligible patient stays that are listed on your CASPER review and correct and QM reports. So we'll talk through that in a minute. It does vary by measure, and so I will be talking about the functional outcome measures, but in the manual that I'll refer to, all of the details for all of the measures are there. There are exclusion criteria. So, for example, in the functional outcome measures, you may be aware that for patients who have incomplete stays, so somebody, let's say, who's discharged to acute care, the functional status of those patients is kind of hard to measure when they're having a medical emergency, and so those patients are actually excluded from the functional outcome measures. There's a risk adjustment approach, there's a calculation algorithm, and there is also obviously a reporting period that's important. So when you're reconciling your numbers, you're going to want to make sure you're looking at the right reporting period. So the quality measure user's manual that I referred to, and again, the link is one of my last slides, provides information about key terminology. So I've kind of given you a preview about inclusion, exclusion criteria. There's a whole chapter talking about the CDC measures and links to important information there. There's also information about the Medicare claims measures. So I know somebody yesterday asked a question about the potentially preventable readmission measure and how do I know which diagnoses are potentially preventable. That information you can get by going into this manual, following the link, and that there's a list that's available. So again, this is a really important document. There's also information about the record selection, the calculation, and again, the logic. And then for the risk adjustment, we use, as part of the measure development, we create regression models, and those coefficients from those regression models are used for risk adjustment. So that information is also in there. So just to give you just an orientation, if you've not already looked at your review and correct reports, this is what they look like. This is obviously a made-up facility with made-up information here, but this just shows this is actually, in this case, the cross-setting process measure, and so you see information here about the number of patient stays that triggered the quality measure, number of eligible patients discharged from your IRF, and the IRF observed performance. So when you're reviewing the data, the number of eligible patients discharged from your IRF during the reporting period refers to the number of IRF patient stays included in the measure calculation after exclusion criteria are applied. Patient records are selected based on discharge date, and it's not admission date, it's discharge date. So just, I know sometimes people have questions about reconciling their numbers and their are starting with people admitted during the time frame, but in fact, it's actually people discharged during the time frame. So just as an example, Q1 2018, which would be January 1, 2018 through March 31, 2018, that would be people discharged January 1 to March 31st. For the outcome measures, in your review and correct, you'll see your IRF's average observed change in mobility score, or your change in self-care score for the self-care measure. And this represents the average change in mobility score, so the difference between discharge and admission for all included patients discharged during that reporting period. Observed is the terminology that we use to indicate that it has not been risk adjusted. So this is your actual change, observed actual change. Just to give you an idea of how we get from the data to this value, so there's a sum of the admission scores that happens. So you're aware any of the activity not attempted codes, so that's the 07, 09, 10, 88, though, and if there happens to be a dash or missing data, that also gets recoded to a 1. I know when we've looked at the data, very little dash codes, so thank you very much. But that is recoded to a 1, so dependent. And so each patient record has scores that range from 06 to 01 after the recoding. All of the mobility items, because we're calculating the mobility score here, are added up. And so there's an admission score, there's a discharge score. In the analysis process, excluded stays are excluded at that point, and so then you're left with the included stay. For each person, the change between discharge and admission is calculated. So if somebody came in at 40, they're discharged at 80, that would be a difference of 40. And then across all the patients during that performance period, that is averaged together. And then there is rounding to one value, one decimal place. I don't want to go in detail on the exclusion criteria for the change in mobility score, but I did want to let you know this is all in that manual in great detail. For each measure, there are different exclusion criteria. So I know I saw somebody ask a question earlier about incomplete stay. There are different definitions for incomplete stay depending on the measure. So in this case, this happens to be for the change in mobility measure, and so you see there's a length of stay calculation. Discharge against medical advice is excluded. And again, a lot of this came from expert panel input. Other criteria relate to the idea that if somebody is admitted independent in all mobility items, so independent in everything, which I don't think that happens, to an inpatient rehab facility patient. Hopefully many are leaving independent, but on admission, if there was somebody who was independent in all mobility items, including our hardest item, pick up the object, don't even need supervision, those patients would be excluded because, of course, mathematically they could not show improvement on this particular set of items. Patients who have less predictable, based on our analyses and from input on the TAP, less predictable improvement, or perhaps, for example, locked-in state, we wouldn't necessarily expect somebody to gain in the mobility items, somebody who's in locked-in state. So that's an exclusion criteria for the measure. So if your facility takes care of those patients, obviously, we wouldn't expect them to gain a lot in mobility. So those patients happen to be excluded. There's also an age exclusion and hospice for this particular measure. So again, I don't expect you to know all those details, but did want to be sure you know that's information that's available to you in the manual. This is the quality measure report, and this is the outcome measure, self-care and mobility in this case. And there's, again, more information here. So there's an ID, denominator. I'll give you a definition in a second. Your report also provides the average admission score, average discharge, average observed change, risk-adjusted change, and comparison. I think, the denominator that's on the report, it basically is the number of people who are included. That's your number of patients. Did want to highlight that if a patient is in your facility, let's say in January, and then they leave, they are away for, let's say, 10 days, so it's not a program interruption, they are readmitted, both stays are included, so a patient can be included multiple times if they are discharged during that same quarter. The admission score is the average change that we talked about, the admission score is the average based on the admission. There's the average discharge score, and then there's the average change score. Because we calculate the change for each patient and then take the average over the facility, you won't see any. It'll be very close, but you won't be able to calculate the change exactly from the average admission and average discharge, just the way that it's calculated. It'll be very, very close, but not exact. The other information that I wanted to be sure you're able to understand is that we report an average risk-adjusted change. If you're interested in the process, that is outlined in the manual, and it refers to basically the information after the complexity of your patients has been taken into account. So if your patients are, on average, more complex based on mobility, admission, based on comorbidities, based on many other medical issues, age, there's many risk adjusters that are taken into consideration. I think for mobility it's about 70 between all the comorbidities and age groups and primary diagnosis. So this number represents after CMS has taken into account the complexity of your patients. And for each patient's stay, the expected change in self-care score is calculated, again, using the results from the regression analyses that have been conducted as part of the measure development. So the last column is the comparison group, and this is the national change in self-care, and you can compare your risk-adjusted change with this national. So again, your observed data is not comparable to the national because if your patients are more complex, we would expect probably would have less change. So the risk-adjusted value is the one that you can compare to the national data. I did want to briefly wrap up talking about the discharge, self-care, and mobility items, and in this case, basically for the discharge measures, it's a percent value. And so basically what happens in order to get to the point of having that percent value is that there's the calculation of the discharge score for each patient's stay. So that again incorporates the recoding. There's an expected score that's calculated based on the regression model work. So again, people who are older are generally expected to have lower discharge scores, to be less functional based on our analyses. Patients with certain comorbidities, so for example, diabetes, renal failure, other infections, cancer. There are, again, many comorbidities that we found in our research that affect patient outcomes. So then the next step is obviously to decide which patient records are included. There are exclusion criteria. They're slightly different than the change measure, again, in the manual, if you're interested in looking at those. And then for each stay, there is a observed discharge score that is calculated and an expected discharge score that's calculated. So given this patient's age, primary diagnosis, comorbidity, and their admission status, what would we expect this person's discharge score to be? And that data those two data points are compared for each person. And the question is, or the next analysis basically says, to what extent did this person achieve the expected or exceed the expected score? So that's basically what the result is. The percent of patients at the facility level, the result that's reported on this report is the percent of patients who met or exceeded the expected discharge score. So on this report, in the page that covers the discharge, you'll see a numerator, and this represents the number of included patients in which the patient's self-care or mobility score meet or exceed the expected discharge or mobility self-care score. The denominator is the number of patient stay records that were during the entire quarter or the entire year, depending on if you're looking at quarter or yearly data. The facility percent represents the percent of patient stays in which the patient stay meets or exceeds, and the comparison group is the national average. I mentioned the quality measure user's manual, so here is the link. Actually, this first is the direct link to the current manual. There is a new manual that's in process, so I did want to also be sure you had the general web page so that when that is put into archives, you'll have an updated manual, version 3.0 to look at, and you'll find it on this measures information. So in summary, I wanted to highlight that we've talked a lot about Section G. Carol covered the self-care activities. I covered the mobility. We covered the changes. We also covered a little bit about the quality measures. Please let us know if you have questions. We're happy to address additional issues about the coding or obviously the reports. If you would like to submit any questions, we'll be having a question and answer session later today. And in terms of action plan, so just to, again, review that, the importance, obviously, of accurate data collection, obviously very important for you representing your patient's abilities. So as you go back to your facilities, you should certainly review the rating scale. Again, the new manual has a lot of coding tips, a lot of what I've covered today. And again, I would encourage you to evaluate your current medical record documentation to ensure your terminology aligns with the current the updated IRF-PAI ready for 2018. So next, ensure that there is a mechanism in place to assign responsibility for collecting the data. Again, keeping in mind that this is meant to be an interdisciplinary approach. We've provided additional examples for you that you can use at your facility. Most of these are not in the training manual, so these are new examples. The answers will be posted in the near future. And I would encourage you, again, to start looking at your reports and help certainly if you have questions, submit them to the IRF-QRP help desk, but I hope you'll start looking at the data and thinking about what I talked about today in order to make sure you understand your data. So with that, I will be passing off to Karen, who will be covering additional topics with us. She's got actually quite a few sections that she's going to be covering.